My name is Mr. Vishal Paringe. I'm one of the orthopedic consultants working in Sandwell in West Birmingham NHS Trust. I've been introduced about this challenge by our very capable librarian Preeti Pugliari. And Preeti spoke to me about trying to describe how we changed our working environment in the current pandemic of COVID-19. Now, it was a real big challenge, and what we thought the theme we could say would be, or the tagline I could say, is virtual is a new real. A lot of things were different before this pandemic, and we were used to working face to face in a physical contact space area, discussing things on the go in a closed space, and we couldn't do that anymore because of the COVID-19 government guidelines. Something had to change and something had to give way. And what we formulated we could do is change our working pattern drastically and go virtual fully. So we started with virtual trauma meetings, and a trauma meeting is a very important start of the day in an orthopedic unit. This is where we discuss all our cases, go through x-rays and plan for management. We used the platform which was available to us in form of WebEx Cisco. This was a platform which was used mainly in the management arena, and probably most of the clinicians were not aware of it. I myself wasn't very aware of it, and then suddenly we had to get adopted to this new technology. So I worked closely with our IT colleague, and I have to thank Julian Mansell, our IT colleague, and Michelle Mills, our trauma coordinators. We got together, sat down, brainstormed how we can make this work, and generated some network connections for using WebEx. It involved a lot of teaching and training and everything else, so we had to get our colleagues to the speed, how to use the technology, the registrars who are going to use it day and night, how to use it, and how to link up with everyone. It went well. It improved the participation of all the colleagues drastically. We were getting much more debated and discussed opinions, and it streamlined the trauma services quite significantly. We were able to then move on to getting theatres to engage into decision-making, planning, and going through a list. And the next step forward is to also get and invite anesthetists to log in as well. So all the decision-making and planning for the day status is done in this step. The second important thing I would say is using the same platform to run our quality improvement half days. Now, trauma and orthopedics have been always excellent with regards to quality improvement half days, and we won the bronze award before the COVID-19 pandemic started for it. And I have to thank my colleague Mr. Bowen Thomas, who is retired now, and he worked really hard with the governance team towards that end point. We were on the verge of being considered for silver awards, so we had to make sure that the virtual or the WebEx based QIHD worked well, and the participation on the first QIHD was astronomical. We had about 66 people participating in that QIHD, and that led to orthopedics getting a gold award, being the only second QIHD in the trust to that effect. We also then went on to virtual MDTs, and the MDTs were run regardless of the time. The opinions were sought more quicker, the decisions were made more quicker, and the patients had better outcomes because of that. We were sometimes running MDTs till midnight. I mean, our upper limb team can vouch for it. They've been running it till 12 o'clock in the midnight, getting decisions for next day's theatre. There were plenty of challenges in organizing this as well, particularly getting used to the different forms of virtual platforms. We had WebEx Meet and WebEx Teams, which I think was a lighter version of it. So we did overcome the challenges, and we were able to tune in all our virtual platforms with our electronic patient record system, Unity. And I think Unity has come to real shining light here because everything was virtual there. So I think almost we were ready for the pandemic without being actually realizing that there's a pandemic coming through. So this was our virtual working. I mean, just to add over there as well, that we did a lot of virtual teaching. Our registrars were receiving the first Monday and the third Monday of the month teaching in the evening from 7 o'clock onwards. Cases were discussed virtually. Journals and articles were discussed virtually with a lot of participation from my colleagues. We had to overcome the challenges with regards to hardware as well. So when the pandemic started, not all of us were equipped with the trust hardware, but our management was really wonderful in providing that support to us. And by the end of first couple of weeks of that start of the pandemic, everyone had the trust laptops, and hardware was provided whenever we needed and whatever we needed. Think centers with camera equipped and also WebEx equipped machines were available to us, so that was really good. Innovation has been the mainstay of the pandemic, and I have to say, virtual clinics in healthcare scenario, which was something which has been tried before but not liked, and then going through run of mill, but now it's come at the forefront really. We did trial with Visionable, and Visionable did prove excellent in doing outpatient clinics, mainly follow-ups I would say, rather than new patients, because we did realize that to do a new patient clinic with an orthopedic problem would be challenging, but not actually seeing the patient. Also, we did speak to the company to see if they could equip their software with range of motion measuring templates and everything else, and that's something that's work in progress, and the company is very receptive to our opinions and advices. Now, going from there, coming to a different arena completely of patient care and healthcare provision on the ground. When COVID-19 pandemic started, we were trying to shuffle resources from ITU, creating the emergency department COVID-19 ready. So we took a lot of minor injuries work towards trauma and orthopedics, and we were dealing with walking woundeds coming in through the door. Now, those walking woundeds coming in, we were treating them as if we were the extended arm of emergency department. A lot of resource went into that, and a lot of resource allocation from consultants being the front line went into that as well. We shortly realized that that may not be the best model, so we decided to innovate this as well. And my colleague, Mr. Kela, who is our virtual clinic lead, then came up with this idea of doing specialist virtual assessment clinics, which were essentially a virtual triaging service of all the patients who came through emergency department, and the emergency department felt it was deemed that they should be seen virtually. So we would then do a virtual clinic appointment. We will decide whether this patient needs to come back to see us in person, and then they were then streamlined into a specialist treatment and assessment clinic, which we call a stack, or a specialist upper limb, specialist lower limb, specialist knee, and specialist foot and ankle clinic. Now, what did this do to it? It really changed the way we are delivering of healthcare. What it did is made sure the right patient was seen in the right place and in line with the GIRFT guidelines. So we were ahead of the curve in trying to adopt the GIRFT guidelines and modulating our service to that effect. The data was analyzed by Mr. Kela and his team, and we had about 85% take up on the SWAC clinic, which is the virtual assessment clinic, and we only managed to bring about 40% of them back to the STAC clinic, which is a huge amount of discharge rate. That is saving of the patient's return journey, improving the patient outcome, and improving the patient experience overall as well. How did we came up to this model? Now, the virtual QIHDs, virtual trauma meetings, and everything else has not been actually practiced everywhere in the country. I think only 1 or 2 centers in London do that, and we were actually ahead of the curve in this area as well, in the whole Black Country Alliance. And we did a small survey trying to understand how other hospitals had allocated their resources, and then we did map out that none of them were actually doing this, and we were far ahead in the virtual arena. Where do we want to take all this from? So we decided that rather giving up on all this when the whole pandemic finishes, we will create a legacy pattern to adopting this in our day-to-day activity. I think the virtual trauma meetings, virtual MDTs, virtual QIHDs are here to stay. Having said that, everyone's missing the element of the physical face-to-face contact as well, because that's important in any healthcare team building, and you need to have that face-to-face contact so you can exchange your opinion, important from a well-being point of view as well. Make sure you check on your colleagues. So that's where we are. Now, what we're going to do is also try and equip our trauma hub with virtual platform ready, i.e. possibly WebEx ready, and that's the system that we're using. And then trial all these platforms so that we can transfer them for the Midlands Metropolitan University Hospital project as well. So we're running that and trialing all these systems. So we've got a very excellent, well-drilled platform in place. Thank you.